I think it's a pleasure to invite Dr. Puneet Dhar. In all fairness, all honesty, I've just done one ampulectomy in my entire career. So welcome, Dr. Dhar.
Thank you. I thought Sanjay was a good friend till he gave me this topic. And, I've just done one less than you. So I think in 30 years, it's the first time I'm going to speak on something I've not really done. And I probably had a bias, but I must confess that reading for it did change my thought process. So terminology-wise, it's called surgical or transduodenal ampulectomy because you actually open up. And I remember the first time I went to Tata on a visit, they used to routinely open up the duodenum. So I guess it's possible to do it. It was first described by Halsted more than a century back, in addition to all his other contributions. And I guess with lower recurrence rates from extensive use of pancreatic it was much more popular subsequent part of the last century. Also, on the other end of the spectrum, less aggressive endoscopic papillectomy was also popularized for smaller tumors. So I guess it really relegated to a very small area. So it is probably forgotten as an uncommon treatment for a relatively rare tumor, the more benign end of the spectrum for papillary tumors. So if you know the legend of Trishanku, where he was a narcissistic king who wanted to take his beautiful body with him to heaven, and Vishwamitra was trying to send it up, and Indra said no human can come with this. So he had to find his place somewhere in between, which is what I think ampulectomy did. So the indications would be for ampullary adenomas, benign adenomas, which are too large for the endoscopist. If it is possible for the endoscopist to take it out because it's only mucosa and submucosa that they can do, then the surgical ampulectomy can be tried, especially if it's a high-grade dysplasia. For low-grade dysplasia, endoscopy is probably adequate. For high-grade dysplasia and carcinoma in situ, probably the surgical, the recurrence rates after endoscopic is very high. It's also been tried for very highly selected cases of early T-stage ampullary cancer, where you can show that there are no nodal or any other metastasis, and which are not moderately or poorly differentiated, especially if they're unfit for major surgery. So that's a bit of a sort of, clearly somebody who do badly, an older comorbid patient who do badly with a major pancreatic. It's not the doing which is a problem, but the worry that they might not recover from any problem should they have one. Finally, it's also with sphincterotomy associated biliary strictures, where normally the first line of treatment would be sphincterotomy, but if there's extensive involvement longitudinally into the biliary the bile duct side, this could be an option. And also finally for rarer tumors like neuroendocrine and GIST, which are localized to the papilla. It has been mooted as a palliative option, but probably in current day and age of excellent gastro and radiological backup, we probably should not be using it for that, but it has been historically used for that. So why is it not so popular? I think the principal reason has been for the diagnostic uncertainty. All the patients where we thought about doing it, like FAP patients where they had a obviously benign ampullary adenoma and such like, you're not sure whether they it's a sampling error. You might get some deeper degree of malignancy. So you don't know whether there's nodal involvement, which is a much higher risk in ductal cancer. How much of ductal extension is there towards the pancreatic side particularly, which might be malignant. And what I had, I think, was the blind spot, which I realized now that probably was wrong on my side. I thought the pancreatic fistula rates and the other complications are probably much higher. So why with the same kind of side effect profile, why go for that? So that's also probably one of the perceived reasons why it was done. So if you do consider an appropriate patient, it's important to look for the potential resectability and the staging, of course, by the standard techniques. But the critical investigation is endosonography, which can tell us the intraductal extension both in the biliary and the pancreatic side, the invasion of the sphincter, the duodenum, and the portal vein. Any lymphadenopathy is probably picked up better with the EUS than with CT or MR. Only flip side is it tends to overestimate, which is probably in its favor. It's better to overestimate than to underestimate. In addition to EUS, either a forward viewing or a side viewing endoscopy should also be done to clearly define the malignant potential, and if it has some of those features, if there's obviously proliferative, apart from the villous ones, if it's got, ulcerations and those typical malignant features, and also look for whether it's on the lesser end of the spectrum and just an endoscopic resectability can be done or not. Meta-analysis actually shows that the tumor size may correlate with likelihood of cancer, but this has not been borne out with some of the prospective studies, so the jury is still out on that. Technically, it's wise to do a pre-op endoscopic stenting to relieve jaundice and aid in the identification intra-op. In case it's not done preoperatively, we can do a cholecystectomy and do an transcystic stenting to make sure that we can locate the papilla properly. So the access can be either by minimally invasive techniques or subcostal or midline incision, explore and rule out metastasis, mobilize the pancreatic area, the cattle brush type, minimal cattle brush to make sure that the entire area is visible. A longitudinal duodenotomy is done opposite the ampulla or a relatively oblique one. Tumors, the tumors, the duodenotomy ends are also sutured out as retractors. The tumor is sutured to retract, to use as a retractor for itself, and a submucosal saline or adrenaline injection is used both for raising the wheal and to reduce the hemostasis. The duodenal tissue is dissected circumferentially. The bile duct and pancreatic duct are marked before transection. You can do this, first do the resection and then the reconstruction together. And eventually you reconstruct the duct to each other and to the duodenum. Alternatively, which is more popularized by Mathil, is you suture as you start going. So you start from the bile duct 11 o'clock and start suturing as you go, because that acts as a counter traction as you pull the tumor on the other side. And then you go to the pancreatic duct at 2 o'clock and then continue and complete the thing circumferentially and then finally join it in the middle. There will invariably be a sort of a duodenal fold which will come, and that will have to be sutured with simple sutures. So that's the end completed reconstruction. After the resection, you might need a frozen section examination because some of these may need to be converted to a pancreatic if they're positive. So that's one of the advantages of doing the resection upfront rather than serially. But even Mathil has described doing the frozen section from the specimen itself. The common walls of the CBD and PD are approximated, and the excess fold is closed, and the duodenal closure is now done transversely to prevent any, because the longitudinal, if we try to close it, it tends to stricture the duodenum, so it should be closed transversely. Drain is not mandatory, but if used, you can do amylase testing before you actually remove it. Again, post-op oral contrast is not really necessary before feeding in the current day and age of ERAS. So I think MIS is going to make significant inroads, and like what MIS did for fundoplication, there was a rapid pandemic of it. I suspect the robotic availability will also make it easier for people to do it because of the sort of technical ease which can be used in the finer setting and the magnification. So the trocar uses as for pancreatic duodenotomy, and you expose till the treats. The ampulla needs to be identified intraoperative ultrasound by using a pre-op stent or a biliary catheter. Similarly, the steps are pretty much similar, and you reconstruct it quite similarly. So that's a photograph from Shackelford actually showing the two stents in place, and the use of a Fogarty to actually identify the ducts and the subsequent reconstruction and duodenotomy closure. So outcome-wise, obviously there will be no randomized trials against either pancreatic or the endoscopic papillectomy, or even MIS versus open ampullectomy. Only observation studies are there. There's a systematic review by Heiss a couple of years back, where the pool R0 rate was an impressive 96.4%. However, apart from this, and many of those studies are not included in the systematic review and meta-analysis, individual studies have shown up to in the tune of 50% may have not achieve an R0 status. The main problem is local recurrence, and bulk of it is nodal. The pooled recurrence is about 9.4%, but individual studies again have shown up to 100%. So I think that is rather than reflective of the procedure, it's probably reflective of the high degree of case selection appropriately that has been probably done. So with that thought in mind, I think it's important that you do lifelong surveillance endoscopy. The pooled complication rate was again not that high, 28%, and even the individual studies didn't show, so I was clearly wrong in my thought process that it causes as much fistula. So pancreatitis was one of the commoner, intuitively, in 10 to 50%. Many of them tended to be mild, some of them could be severe. Hemorrhage was also seen in a small proportion of cases, sometimes needing re-exploration because probably use of adrenaline and all that. Wound infection rates were about 5 to 20%. The pancreatic fistula itself was fairly rare actually. Biliary fistula could also be possible, duodenal leaks, cholangitis, and other rare complications. Mortality risk was significantly low, and I think that's an important message, that in 532 pooled cases, only 5 deaths were there. So again, it's probably reflective of the highly selective, good risk patients, you could argue that the same. That's why most of the people do it for unfit patients, but seeing good results, many people wonder whether we should be doing it for fit patients, so that's been liberalized. The long-term survival data are less consistent, less available as well, but from what is available, it's 10 to 77% 5-year survival. Obviously better for the lower stages, so if you only look at the T1, T2, it's between 20 and 40 in most series. And again, there are complex balancing risk factors with poorer comorbidity risk versus use in the earlier stages. So it's a mixed bag. The future RCTs is unlikely. It would maybe borderline ethical. Robotic resurgence is likely, and there is an ESAP, the European study comparing endoscopic surgical ampulectomy versus PD, which may give some clues for a potential algorithm. This is a retrospective multinational study. To summarize, ampulectomy would be a decent choice in a highly selected subgroup of patients. It's an intermediate excision between endoscopic papillectomy and formal PD. We should avoid it in doubtful diagnosis, higher grade or higher stage tumors, any metastasis, and it's best for the elderly in comorbid, and high rates of cure with a low complication profile is possible. I thank you for the patient listening and bring you greetings from Amrita Hospital.
Thank you for the wonderful review. Any questions from the floor?
Presentation, sir. So 2 questions. One, what is the selection like if the pancreatic duct may not be dilated, CBD may not be dilated? So at that aspect. Second thing, generally when you place a stent, we need to operate after 4 weeks. But here we can do it in case if the stent is not placed, can we do from cholecystectomy and proximal that could have helped?
Yeah, I mentioned in both the robotic, that the second part, it can be, you can do it through a cystic duct approach if you're doing a cholecystectomy. What's your first question? The ducts are not dilated. So basically, its premise is it's a papillary tumor, so ampullary tumor, so it would be dilated in most of them. The exceptions probably IPMN where it's growing discretely, and now most people are not doing for IPMN because there is a field effect as well. So by and large, it would be there. If it's clearly not dilated, may not be the best approach, but it's still possible to do it. If you think you can achieve a mucosal anastomosis, it should be still possible.
After reviewing the literature, on a personal note, what will you recommend?
So I think for the, at least for the clearly benign with no endoscopic features of malignancy, I would definitely like to try it, yeah. Especially in cases where, like FAP and all, where they're likely to have multiple other operations. They might need pouches, they might need other malignancies as well. So I would definitely, the induction of desmoids is higher. I would definitely try it for those.
See, if it is T1A, there is no lymph node metastasis. If it is T1B, like submucosa, that's the anxiety at the back of the mind when we take a patient for a surgery. Any further questions?
So that's true. With as increasing stage, the risk of nodal mets which are even missed is higher. So that is obviously a risk.
Regarding I think the surgical steps, I think it is a good presentation, but surgical step, you told duodenum to be opened longitudinally and then closed transversely.
Yeah. So relatively longitudinally, but typically most people would do it slightly oblique.
Yeah, oblique incision and oblique closure, same closure.
So you actually tend to make it more transverse, because this longitudinal. So when you if it's a the old days when they used to do it, they actually did close it like a Heinrich-Mikulek's kind of a thing.
So we tried, but it is never possible transversely to close
No, for
the duodenum.
trauma I've done that certainly. Yeah.
Second, when you are showing that when you are doing an ampulectomy, after that you showed few sutures in the duodenum.
Yeah, so you'll be left with a bit of the duodenum open. So, you've got a larger, you've taken a circumferential thing, this is the bile duct and the pancreatic duct, you've got a larger area around it. So when you stitch this to the duodenum, you'll be left with this open area. So you need to close that separately.
So we used to try to get it up to the bile duct and the ampulla. That is normally what we have been.
So yeah, so I mean,
even
even the buccal closure for this thing, they tend to use the entire duct. So I feel there's too much of pancreas behind the duct, so I do it a ductal mucosa only, even in a Whipple reconstruction. So I guess you'll be left with some duodenum, which is, if you try to, what you're saying is try to distribute the entire anastomosis. So if it's possible to do, but I wouldn't definitely not like these ducts stretched. I would be very scared about stretching the pancreatic duct particularly,
Yeah, please. So I think I agree with you that low-grade neuroendocrine tumors, purely localized disease, older patients, you have a chance to do a regional lymphadenectomy and an ampulectomy and avoid a Whipple. Say a grade 2 neuroendocrine tumor, localized disease, 78-year-old gentleman, you need not offer a Whipple. Low indolent biology, but a lymph node met. You can do that in selected cases. The other thing would be PT1A, but T1A already the concern is about B and something more. So we would have a lower threshold there and do a Whipples more often than not.
So clearly only for the unfit patients. So although many people do it for the fit.
The unfit one and the truly, I think the low-grade neuroendocrines is a better entity. And I agree with you that you will have both duct dilatation. In fact, if you don't have duct dilatation, you need to be careful, and the chance of pancreatitis dramatically goes up. However well you might do the recon with a small duct.
Yes.
Can I ask?
Okay, I think that's going to be the last comment. Yeah.
Yes, sir.
How many cases have you done? Because in a series of about 778 Whipples, we've only done 3 ampulectomies. And I can't understand the justification for doing ampulectomy in a person with a lot of comorbidities. Why not just put a stent in?
So it's more for the benign. So the first question, I already took anticipatory bail that, in 30 years I'm talking on something I've never done. So the answer is 0. But I would probably do it for the completely benign for sure. I'm not still sure, I would change my thought process on T1 exactly for the reasons that Shailesh said, that there might be, a higher grade than you imagine. So only for the benign, clearly benign, sir, I would do it. So I'm not,
Yeah, I think most of us haven't done this procedure because of the rarity of the situation that you don't find really the T1 lesion. In clinical practice, most of even the ampullary tumor, invariably the patient comes with jaundice or ulcerations where the tumor, your biopsy is positive, or the patient is clinically already advanced not to warrant this procedure actually. So I think clearly, this mainly in cases of fat or sometimes anecdotal cases where we really find the
low-grade
small
nets
tumor
and all, yeah.
as such. Okay, I think we have really interesting discussion.